no a guaranteed method in which someone can say which one is going to be successful, because the literature is controversial. However, if you draw a line like what has been drawn on that X-ray along the femur, and a perpendicular line to this line, which is perpendicular to the mechanical axis of the femur, at the level of the distal femoral resection, if it is proximal to the attachment of the collateral ligaments, you will not be able to use this method. So you will not be able to do intra-articular correction if this distal line passes proximal to the attachment of the collateral ligaments. Similarly, in the tibia, a line is drawn along the mechanical axis of the tibia, and if that line goes out of the proximal tibial plafond, if it goes out of the proximal tibia, then you will not be able to correct that using the intra-articular method. So whether you do a single stage or a two-stage procedure actually depends on how how much of the deformity you are going to correct. Is your patient going to willing for the surgery, or the other clinical situations like the stiffness, skin, and the patient is willing to have second anesthesia and surgery. Several methods of fixations are available. You can use something like an intramedullary rod, something like this, or plates, depending on, or you can have a long stem along with the knee replacement itself. So some of the observations for this extra-articular deformity is, if the apex of the deformity is closer, more release will be required. So they are more difficult. For example, if somebody has a very proximal femoral deformity, it's not that difficult. Whereas if it is very distal in the tibia, it's not that difficult. Deformities extra-articular are easier to correct if it is in tibia, whereas it's in femur it's difficult. 20 degree or more, soft tissue balancing will be difficult, and you may need a lot of bone resection. So you may have to correct these deformities extra-articularly. So there are some studies, but most of them have very small numbers, something like this, with 11 patients only in this study. They said the most of these things can be managed intra-articular release only. This is the main advantage of the computer navigation. I'm sure you're going to hear a lot about this in the next couple of talks. This calculates mechanical axis irrespective of the deformity and irrespective of the hardware which may be there in the distal femur. And in fact, this is one of the classic indications for the computer navigation nowadays. And also, this can be used if you are going to use a concurrent osteotomy to correct the deformity as well. So a couple of examples. Previous trauma, distal femur. You have both coronal and sagittal plane deformities. You could have done a distal femoral correction and then go for the knee replacement. I choose to do a navigated one at that time. It was about 5-6 years ago, using the first of this striker navigation system, and we use this navigation system to get the mechanical axis and the component position reasonably well without correcting the deformity. So similar situation like this, you have not much of deformity, but lots of hardware in the distal femur. Patient has come for a knee replacement after the conservative methods and everything has been failed, relatively younger patient. You could choose to remove all the implants and do a knee replacement, or do something like a customized zig without removing the implant, which reduces surgical time, implant removal, etc. Similar patient with a proximal femur fracture. This was fixed first, and then you see the knee is completely damaged. You have metal inside and deformity. That was managed again with the computer navigation, and because the conventional instrumentation cannot be used. But you don't have to do that all the time. We did the similar calculation in this case. There was a little deformity in the proximal tibia. However, we could manage that without correcting the deformity, but intra-articularly, even without using the stem or any specific, any special. One, proximal tibia, quite a lot of deformity. The deformity is not corrected. And if you see a long standing X-ray, you can see the mechanical axis is restored well, and the patient is doing well. And if we had to correct this deformity, it would have been a really longer surgery and probably unnecessary in these kind of cases. Thank you very much. Thank you.